presentations. We're going to go ahead and get started now that it's 12 o'clock. So thank you all for joining us today. My name is Amy Etzel, and I am the Implementation Manager with the Bree Collaborative. Before we begin, just a few quick announcements. NCLAC will accept attendance at this webinar session as a CE event. To receive credit, you just need to document your time and submit a short survey. You'll receive an email later today with a link to the survey, along with today's presentation slides and resources. Please remember that if you want a certificate for a credit hour, you must provide either your RN license number or an equivalent ID number, and then complete that survey by next week. I will put a deadline in the email that I send out. If you have any questions about this, please contact NCLAC directly. You all are currently on mute, and you will be throughout the course of this webinar until after our presentations. Today's speakers would love your participation in a Q&A discussion at the end. If you have any comments or questions, please feel free to type them into your chat box, and then I will use them to facilitate our Q&A session. Today's speakers declare no affiliation with or financial interest in a commercial organization that could pose a conflict of interest with the educational content of this program. All right, so that ends our housekeeping portion of today. I'm just going to give a very quick background on the Bree Collaborative itself and our guideline development process. We are a public-private group in the state of Washington formed by our state legislature in 2011. Our goal is to improve healthcare quality, outcomes, and affordability throughout Washington state. Our collaborative members are made up of healthcare leaders around Washington who represent health plans, healthcare purchasers, including our state Medicaid agency, as well as private purchasers. And we also have representation from delivery systems across the states and other quality improvement organizations. Every year, we select 3 to 4 healthcare services with variation in delivery or outcomes that are used inappropriately or too often, or maybe they're not used enough, or that have a patient safety issue or an equity issue that our community cannot address in any other way. in any other way. Our recommendations are informed by clinical committees or work groups made up of community members with expertise in that selected topic. This collection of volunteers meets for about 9 to 12 months, and then in these work groups, we review published literature, guidelines from specialty societies, work of other quality improvement organizations, national entities and programs, and policies within our own delivery systems. As you can see, we have worked on a wide variety of topics, starting with obstetrics, looking at appropriate C-sections, and have also developed best practices for topics such as low back pain and end-of-life care. So our suicide care report and recommendations were adopted in 2018. Today's speakers, Jeffrey Sung and Kate Comtois, were both part of the work group that developed this report, and they have helped us identify these 6 focus areas of suicide care that make up the recommendations. As part of the Bree's implementation efforts, I've been developing some starting ground implementation resources that will be emailed out with our slides later today. The first here is an implementation checklist for clinical settings outlining these 6 focus areas and the various action items clinics can take toward implementation of our recommendation. And on the back of this checklist, we'll have some additional resources that are called out in the full guideline itself, as well as some links to further information regarding the evidence-based treatments recommended in the report and the various screening tools that we recommend. I've also identified some basic core process measures for clinics to focus on, particularly for clinics that are in the beginning stages of developing a suicide care protocol. All right, so now I'm going to turn it over to our speakers for the day, Jeffrey Sung and Kate Comtois. Jeffrey is an acting instructor in the University of Washington Department of Psychiatry and Behavioral Sciences, and he also maintains a private practice. Kate is a professor in the Department of Psychiatry and Behavioral Sciences and an adjunct professor in the Department of Psychology at the University of Washington, and co-directs the Harborview Psychotherapy Clinic, which includes one of the longest-standing DBT programs in the country. They both have contributed extensively to the world of suicide care throughout Washington and on a national level, and we are so lucky to have them sharing their extensive knowledge with us today. And so with that, I'm going to go ahead and give control over to Jeff and Kate.
All right.
All right, Jeff and Kate, I think that you, there you go, perfect.
All right.
So, so this is Jeff. You guys can see our first the overview slide here. Kate, do you want to say hello?
Hi, this is Kate Courtois.
Great. So the webinar, you can see Amy has these different focus areas. We've chosen to focus on the care itself rather than some of the follow-up sections. So we'll give you an overview of what we mean by suicide care. We'll talk a little bit about the barriers to implementation. We understand that that there are varying factors that are making it more or less difficult to implement the care that we think is going to be of high quality. We'll go over in a little bit more detail, broad overview of the different components of suicide care, the identification, assessment, management, treatment, and follow-up. We'll give a clinical example of what we think an ideal circumstance would be if someone moved through a clinic using the workflow that we've described. And then we'll hopefully have some time for questions and discussion. Okay. So the story of suicide care that I'll sometimes refer to is, so these are the interventions that take place in all kinds of healthcare systems for all kinds of health problems. That at lower levels of risk, we try to identify risk at the top left. We do further assessment. We formulate the risk. We engage in immediate management strategies to try to stabilize the problem and keep people alive. And then we engage in treatment interventions that try to resolve underlying problems. And then we have follow-up care during the course of this. So when I'm talking about suicide care, I'm talking about these clinical interventions. I will distinguish that from suicide prevention, which tends to be higher level, broader public health strategies. And so when I say suicide care, I'm talking about our screening assessment, risk formulation, management, treatment, and follow-up. There previously was a document from 2011, I think it was, called Suicide Care in Systems that looked at healthcare systems or other systems that implemented broad scope clinical interventions for suicide risk and published a document that provides this sort of framework. In regard to the barriers to implementation, Kate and I that think about this a lot, that we have the idea that what would be high quality suicide care and then what makes it hard to implement that. So this question, the relative paucity of high quality care, what does it relate to? And then on the right, these are all of the potential answers to the question, why is it that we do not have more effective suicide care? And so on the top right, there orientation failure. So it's possible that clinicians have never been instructed on how to engage in this care. Or it might be skills deficits, that the clinicians have not learned the skills of suicide care, practiced, or generalized them. It could be emotions. Sometimes there's discussion around clinicians being fearful of working with suicidal patients. Or it could be cognitions. So these are myths about suicide that there's a common myth that asking about suicide might plant the seed. So we're sometimes trying to correct cognitions or beliefs. And then indecision, that organizations or clinicians have not decided that this is what they want to do. And so this list, the orientation failure, skills deficits, emotions, cognitions, indecision, these are barriers that are potentially addressed by training. So more training in suicide care. And then in contrast, at the bottom, contingencies that affect suicide care. And so if you ask clinicians, what's getting in the way of you implementing best practices, oftentimes it's, well, we don't have enough time, or I don't get paid for that work, or you can tell us to manage people on an outpatient basis. The problem is that if we engage in these lower level interventions, that puts us at risk of medical legal liability. And so therefore we refer people to emergency department or inpatient hospitalization. And so when Kate and I talk about what are the barriers to suicide care, oftentimes we're talking about payment, regulatory, and legal systems that are interfering with the quality of care. That when we try to implement these best practices, we come up against the fact that they require much more time. They require different payment models than we have established right now. So we'll present a vision of what the best practices are. We realize that we might not always be able to implement these. If we can come up with a model of care that we think is successful, then we can start to set the agenda for where we want to go and address these implementation issues. So maybe we can talk more about that later. So let me move into the different components of suicide care. So at the lower left there, the Bree recommendations for risk identification. This is a summary. So screen the patients over 13 for behavioral health conditions using the validated instrument, so including screening for depression and suicidality. And so if you have access to the clinical tools documents that we sent out, or actually, let's try to just share it on the screen. Okay, so our risk identification, so again, we understand that the clinical tools that we're recommending are not necessarily, we don't know that these are the absolute best tools. We chose tools that are easily available, typically publicly available, public domain, non-proprietary, and familiar to people. So that doesn't necessarily overlap with, we are convinced that this is the absolute best tool. And so the tool that we have described or suggesting for risk identification is the PHQ-9 Patient Health Questionnaire. So oftentimes these are implemented in medical settings for depression screening. Question number 9 on PHQ-9 says for over the last 2 weeks, how often you've been bothered by thoughts you would be better off dead or of hurting yourself in some way. And so there is data to indicate that when people screen positive on this, so scores 1, 2, and 3, they have elevated suicide risk or risk of suicidal behavior. And so we are commonly recommending PHQ-9, number 9, as our initial screening question. Okay. So, so then if someone screens positive on the risk assessment tool, so let's say the front desk staff gives someone a PHQ-9, they score positive on PHQ-9 number 9, they score like 2 or something like that. And so then the medical assistant will take that and then give the patient a clinical tool for further assessment. So when we're talking about suicide risk assessment, all of suicide risk assessment will include the other risk factors for suicide. So what are these stressful life circumstances, situational stressors, the mental health symptoms, depression, anxiety, insomnia, psychotic symptoms, etc. And so when I'm talking about suicide risk assessment here, I'm talking about just specifically the suicide specific assessment. And so the clinical tool that we're recommending for the suicide specific assessment, the clinical tool that you use if someone screens positive on PHQ-9 is called this screening version of the Columbia Suicide Severity Rating Scale. We're going to call it up here. And so someone screens positive, PHQ-9, medical assistant then administers or provides the Columbia Suicide Severity Rating Scale. And so there are many versions of this. You can go to the Columbia Lighthouse Project, and they have different versions of the screening that are used in different settings. And so this is one that's used in like primary care, ambulatory care, and it has some suggestions for what to do with the information. So that's going to be what we talk about risk formulation. So if you look at this document, there's questions 1 and 2. So these are lower level questions. These questions can also be used for the risk identification. So if you don't want to use PHQ-9 number 9, you can use the first 2 questions of the Columbia Suicide Severity Rating Scale. So number 1 is about passive suicidal ideation. Have you wished you were dead or wished you would go to sleep and not wake up? And so those would be wishes to be dead, not necessarily active thoughts. I would do something about it. So question number 2 is going from active suicidal ideation, or it's from passive suicidal ideation to active suicidal ideation. So question number 2, a clinician says, I'm going to ask you, have you had any actual thoughts of killing yourself? And so then we call this hierarchical assessment of suicide risk. That means we go from lower levels of suicidal ideation to higher levels of suicidal ideation. If your patient answers no to any of these questions, you can stop screening or stop your assessment. And so if someone answers yes, yeah, you go to number 6. And so if someone says yes to 1 or 2, then you continue to ask these questions 3, 4, and 5. So question 3, so now we're asking about the suicide method. Someone has active suicidal ideation. We want to know if they're thinking about how to do it. Have you been thinking about how you might do this? Have you thought about pills? Have you thought about firearms? Have you thought about that suffocation? And so then question number 4, if someone has suicidal ideation with method, so now you ask about suicidal intent. Have you had these thoughts and had some intention of acting on them? And so then you can see on the screening, as opposed to I've had these thoughts, but I definitely will not do anything about them. So a clinically relevant distinction, because sometimes you'll ask people, have you had thoughts that you wish you were dead? Oh yes, I think it would be better if I were dead. And then you ask them, have you thought about killing yourself? Yes, I've had actual thoughts of killing myself. And then you ask them, well, do you intend to do it? Oh, no, I would never do that. I'm afraid of what that would do to my family. And so that would be like suicidal intent. So if someone says they have suicidal intent, then you ask about any specific plans. So have you started to work out or worked out the details of how to kill yourself? Do you intend to carry out this plan? And so within this assessment scheme, a suicide method is how they would do it. So that would be firearm, suffocation, overdose, and the suicide plan is the details of what they would do that day. Like they've organized the pills, they've chosen the day, they've chosen where they would do it, they've written a suicide note, so that would be a suicide plan. And so then question number 6, so now we're moving from suicidal ideation to suicidal behavior. So have you ever done anything, started to do anything, or prepared to do anything to end your life? And so within this risk assessment scheme, we're asking about suicidal behavior, suicide attempts, self-interrupted attempts. Someone started to do something, they stopped themselves. Interrupted suicide attempts, they started to do something and then someone else stopped them, or preparatory behavior, they started gathering pills, they started researching purchasing a firearm, they started looking up highest building in Seattle to jump from, so those would all be different kinds of suicidal behavior. And so if someone has suicidal behavior, then you ask them, was this within the past 3 months? And so this is our so-called suicide-specific assessment. So in addition to the other risk factors, which would be the stress in their life, their psychiatric symptoms, demographic risk factors, now we want to know how far down that road of suicidal ideation behavior have they gone? Okay. Yeah, so let me, what should I do? Let me just keep going with this. So, so now that we've done our suicide-specific assessment, now we are talking about risk formulation. And so we are still using, so the clinical tool that we are suggesting here, and there are other clinical tools. So for example, the VA out of Rocky Mountain, what's it called?
MyRac?
The Rocky Mountain MyRac, they have a risk stratification scheme that will also help you categorize risk into low, moderate, or high. And that's based on long-term or short-term acute or chronic risk. So what we're suggesting here, the Columbia Suicide Severity Rating Scale. And so based on your suicide-specific assessment, Columbia Suicide Severity Rating Scale makes some suggestions on how you categorize that risk, low, moderate, or high. And so that's sort of that like yellow, orange, or red. And so if someone has questions 1 and 2 only, so they have suicidal thoughts, but no method, no intent, no plan, no recent suicidal behavior, then we categorize their risk as low, and then we are suggesting behavioral health referral. If someone has suicidal ideation with a specific method in mind, then we're calling the risk moderate, and then we want more immediate referral and then taking some safety precautions. If someone has suicidal ideation and then they have some level of intent, or if they have made a plan, or if they have suicidal behavior within the past 3 months, then we make a clinical judgment that their risk is high, and then we engage in more immediate behavioral health consultation and then take some patient safety precautions. And so this is one risk stratification or risk formulation scheme that you might use. So should we keep going?
right? Yeah.
Yes. Okay. So Kate's going to talk more about management of suicide risk. So she and I were talking about like an analogy. So for example, I slept wrong on a bad air mattress years ago and ended up with back pain, and I basically just did nothing about it and took naproxen for years, and so finally went to the primary care doctor and was referred to physical therapy, which in contrast to the naproxen, which kept things going but didn't actually solve my problem, physical therapy actually resolved the problem. And so we can make this distinction between a management strategy that sort of like gets you by and takes care of some immediate symptoms, and a treatment strategy that actually resolves the risk. So Kate's going to talk more about how we think about this distinction between management and treatment, and then some more specific management and treatment strategies.
So one of the things that we see happen very often when people, for all the right reasons, kind of really lean into suicide care is there's the focus starts to kind of hone in on the management, and then the treatment piece doesn't get addressed. And then just like Jeff and his back pain, the back pain is continuing. So you all are continuing to work with somebody who is at continued suicide risk because the actual things that are keeping them at risk are persisting. So one of the things we really want to make people are really clear about is management is an absolutely necessary component, but it isn't sufficient to actually make this problem go away in most circumstances. Sometimes when you engage in management, it actually sort of engages the person or engages their social network in a way that actually changes their life circumstances. And then they're sort of getting treatment in the world. They're not getting treatment from us. So sometimes, in fact, getting this mobilized is sufficient. But in many cases, it's really not sufficient. So what we really want to think about is that suicidality is often for us, suicidality itself is the problem, but for the patient, it's actually a solution. That's how they're experiencing it. It's a way of responding to life stressors. And not everybody goes down that path. So one of the things to think about that's really important to being able to work with suicidal individuals is to recognize that in the face of life stress, many people, the majority of people, go down a non-suicidal pathway and figure out how they're going to deal with it, and maybe they deal with it effectively, problem solving, getting the problem solved, or ineffectively, maybe they're drinking or they're using marijuana or they're avoiding their family or whatever they're doing, but it's not a suicidal pathway. And that certain people go down this pathway toward suicide and see that as their solution to the problem. And one of the things we talk about a lot in suicide care is this idea of these drivers. What is driving the people who end up going down the suicide pathway to go down that pathway and not be like everyone else? And that's a lot of where the treatment comes in, is if we can get rid of those drivers, then they become like non-suicidal copers. So we can't do that, of course, if they're dead, or if they do something really awful and they end up with some terrible physical consequences. It's not going to solve the problem. So management is a necessary component. And the things to be thinking about in terms of management is that you're seeking to reduce the immediate risk by modifying the risk factors that are directly tied to their suicidality, and that it's optimal but not necessarily going to be a collaborative process. You will encounter folks who you discover are at high risk and are not willing to pursue care, and sometimes things end up going down a less than collaborative pathway. A lot of things we're hoping is going to give you options that don't send you down that pathway, but we all know that reality exists. So the kind of things that you want to be thinking about in terms of management are continuity of care. So how do we know who's on deck to be helping the patient at any given time? Are the transitions actually happening? So people often talk about suicidal folks falling through the cracks, that they get referred to a follow-up source, but they don't make it to the follow-up source, and then the follow-up source doesn't sort of know how to go forward to keep that process going. So the person who's referring really has to keep their eye on the ball, and that's often, of course, you all. And that's really in many ways one of the most important roles of primary care. Is the specialty care is frequently kind of got a narrow time window, right? I'm going to see this person for a month or 2 months or 2 sessions or 6 months, maybe if it's a long-term treatment, but it's not part of their ongoing life experience the way that primary care is. So you guys are in a very unique role to be the one who has the window to what's happening for this patient, and you're all experts at it. You do this for suicide, but you do this for many, many other diseases as well. Management may include psychiatric treatment. People often think of psychiatric treatment as the treatment, but the evidence that we're seeing increasingly is that there isn't a treatment of a psychiatric disorder. The possible exception of clozapine with schizophrenia, where we can clearly show that if you put psychiatric treatment in place, the risk necessarily goes down over the next month or year. There's some evidence that maybe what's happening that explains why those two are not, they're kind of correlated, but maybe not causative, is maybe that there's some third factor, like some of these drivers and stressors we've been talking about, that's leading a person to depression. It's also leading a person to suicidal thinking, but not necessarily through the depression. And therefore, it may not, and certainly antidepressants are a good example, where depression can resolve even if their suicide risk doesn't change. And you can also see very frequently the opposite, people's suicide risk coming down even though their depression hasn't changed. So I think that's an important thing to be aware of, is that these don't always kind of have that causal relationship we think that they would.
Lithium might be anti-suicide.
Why don't you?
So in regard to the psychiatric treatment, it is possible that lithium could be anti-suicide. So it's not confirmed in randomized control trials, but meta-analysis of randomized control trials that did not necessarily look for suicide as one of their a priori outcomes suggest that lithium might have anti-suicide effects. So we don't know 100%.
There's a large trial on currently in analysis in the VA that may help us answer that question. And the other caution with suicide is it's not a great, I mean, with suicide, lithium in large quantities is also a risk. So if you're using lithium for suicide preventive factors, which I think, there is some evidence for that, you also want to keep an eye on them not stockpiling those medications. In particular, as opposed to Prozac or other antidepressant. So the other thing that we want to do to manage immediate risk is what we have come to call safety planning, that includes means safety. So for safety planning, what you want to do is engage the participant or the patient, and sometimes with their family members, in a collaborative process of thinking through how they came to be at risk, what it looks like during periods of high suicide risk, and what are strategies that you can use to reduce it. So the safety planning template that most folks are using is one developed by Barbara Stanley and Greg Brown that kind of has a very particular order. And this is something that the primary care physicians might be doing, but we're more anticipating that by the time you're getting to this step, that when you have behavioral health clinicians in-house, that this task is moving over to them, and that we can discuss that further shortly. So what the idea here is to develop an idea of what are the warning signs. So for instance, if somebody has, you discover from your risk formulation, has had a recent point where something went wrong. They had a recent breakup, or they came to, you find out that, you know, you're seeing them for a follow-up after they were in the emergency room. What we usually do is what we think of as sort of a suicide risk curve. Like, we just sort of follow with them. How did it build, and what was the worst point, and then sort of how did it resolve? And that helps the patient understand that this is something that comes and goes, and that that's what the safety plan is for, is to kind of let time be their friend and be able, you know, there's really good evidence that distraction is an important tool here. If you can let time pass, the risk will come down. And then, of course, it may come back, but that this is something that they can actually do something about. This doesn't have to be something where the health system or other players have to do this. This is something they can learn to do for themselves. And so once you've identified what those those warning signs might be, so maybe the contact, if somebody's gone through a bad divorce, maybe contact with the spouse, being alone in their house where their spouse used to be, thinking about the future without their spouse. These might be things that are warning signs that they're about to go down a pathway toward suicide risk. And so the idea is that you're walking them through internal coping strategies, things they can do themselves, because often when people are suicidal, they're alone, there isn't somebody there. How can they engage people to provide distraction? That means not asking them for help, but just being around other people, or going to places, going to an AA meeting, going to the mall, going to the movies, going down to Pike Place, going for a walk. And then people who can actually help them, and then getting down here to step 5, where then we are engaging the health system. But again, the goal here is to try to give control of the situation as much as is feasible to the patient so that they can manage this themselves, but recognizing that if steps 2, 3, and 4 are not working, that it's very clear who they're supposed to call and what they're supposed to do to reach out. The other thing that we want to do is make sure that we're counseling them around any kind of lethal means that they might have in their environment that would make them at more risk. So a firearm would be the greatest risk. You absolutely want to know whether or not they have access to a firearm, but also if there's somebody who is considering carbon monoxide, do they have a garage? Do they have a way of actually doing that? And if so, what can be done to make sure that they, for instance, aren't parking in their garage, and they put in a whole bunch of, you know, I get creative with people, like, you know, what else could we put in your garage so you couldn't get your car in the garage anymore, or at least without a lot of difficulty? Because again, in that spirit of that risk curve, often if you've made the environment safer, by the time that somebody could do something to make it unsafe again, they're heading down the far side of that curve. And again, we're thinking at this, you know, in many places with an integrated model, that this step would happen with the behavioral health clinician or consultant in your practice.
This slide on lethal means safety. So historically in the suicide prevention field, lethal means safety was called means restriction. The more contemporary term we use is lethal means safety. And so one step of lethal means safety that someone who's prescribing medication might want to think about. So here's a list of different things. So if someone is at risk of suicide, even if they are not expressing suicidal ideation, there are things that we can do with people's medications to try to moderate that risk. And so switching medications to lower lethality, reducing the amount of medications that people are getting, speaking with their social supports, so husband, wife, friend, partner, etc., to help hold medications. People can store medications at work, or people can put a copy of their crisis plan photos of family members next to their pill bottles. So I had some patients who are being prescribed amitriptyline. It was like amitriptyline 100 milligrams for insomnia and pain, which amitriptyline, obviously tricyclic antidepressant, is toxic in overdose. And so our lethal means safety intervention was to switch from, I think one guy went from amitriptyline to gabapentin. I think another guy went to pregabalin. One person we got off amitriptyline. The other guy we got onto 25 milligrams and had switched from 90 days to 2 weeks at a time. So lethal means safety, looking at prescription medication.
So the other piece is treatment. Now, clearly at this point, we're in the territory of your behavioral health clinician or referral to specialty care. But I just wanted to say a couple of words about kind of what do we know about evidence-based treatments for suicide care. And there are now evidence-based treatments that are shown to reduce suicidal ideation or suicide attempts in randomized clinical trials. So they really have gold standard evidence. And one of the things that we see that is really central to these treatments that work is the ability to maintain a collaborative relationship to prevent the dynamic between the clinician and the patient to get into the kind of contentious area that it can when there's debate about hospitalization or other situations where the control might be taken away from a patient, particularly a patient for whom suicide is their mechanism of problem solving and their mechanism of getting control. You can end up in a really toxic dynamic that drives the patient away from treatment and away from help. So that's a core element you see across all of these evidence-based treatments. And the other is a focus on resolving suicide risk until it is resolved, as opposed to a focus on the psychiatric illness or a family dynamic or other sort of psychiatric or psychological issue. Those things may be a major topic of conversation because they're directly tied to resolving risk, but the clinician's mind is focused on the resolution of risk until it is resolved. And once it's resolved, then the treatment can move over into these other areas. And what we found is by remaining collaborative and keeping the resolution of risk as the top priority, risk resolves much more quickly. And we can see anywhere from 8 weeks, some interventions 10 weeks, 16 weeks, and then for more severe or chronic situations of really chronic suicidality, 6 months or a year of care. But it is not schizophrenia. It's a disorder or a problem, suicidality, that is responsive to treatment. The limitation, of course, is that treatment is necessarily collaborative. So if the person isn't going to go into the office or isn't going to engage with the process, then that is a major limit of treatment, of course.
Just a comment on the picture here, just to highlight again what we're meaning by collaborative. Sometimes in other conditions, like we talk about cancer care, there's this idea of we're going to work together to beat your cancer. So the clinician makes emotional, psychological, mental separation between the client or patient and the suicidal process. The clinician or therapist joins with the client, and together they look at trying to resolve suicide risk. And so that idea of the mental separation, that the patient and suicide risk are separate, and that you're going to try to join with the part of the patient who wants to live, and together you're going to work on trying to resolve suicide risk.
And our goal, as I think I've implied a little bit with the safety plan, but what is also really an important part of suicide treatment is that through this this relationship then of partnering together against managing suicide, the therapist can move more into a consultative role and is stepping back, and the client themselves is managing suicidal ideation as it appears going forward. What you often see is that a resolution of suicidality will happen over the next 1 to 3 months, and then it will, reappear in the future as circumstances that are sort of triggers for the individual appear. And in many cases, once they have learned some cognitive strategies, some behavioral strategies, skills, then they're able to respond in the moment when the thoughts of suicide come in a way that manages that risk themselves and gets themselves redirected to the problem at hand instead of suicide, which is often a way of escaping the problem. So I just wanted to highlight that there are a range of evidence-based treatments. These are characterized from least to most intensive. So there are things called a process called caring contacts that would be the least intensive. This is where a clinician is sending messages either via paper mail, or we just recently completed a study with text messaging to the individual over the, repeatedly over the course of the year. It's a very low-level intervention, but has shown to reduce suicidal ideation and suicide attempts in previous studies, and in one study, reduce deaths by suicide. So we often assume we need a very high level of care for suicidality, and the evidence doesn't actually necessarily support that. And then there's other interventions that kind of move up the list. The Attempted Suicide Short Intervention Program, or ASIP, it's about 3 to 4 sessions. CAMS is about 8 to 12 sessions. Brief cognitive therapy and cognitive therapy for suicide prevention, we're getting into the 10 to 16 sessions. And then dialectical behavior therapy, which is designed for chronic ongoing suicide risk, is more at the 6 month, 1 year, sometimes more than 1 year intensity. And so of course, the farther you go toward the more intensive, the more that's going to take place in specialty care. So just in summary, we're just trying to kind of help you think through the difference between management and treatment here. That management, which is optimal when it's collaborative, our goal is to reduce the risk, and often that involves external factors as well as working on kind of an internal process. Whereas treatment, which really is necessarily collaborative, the goal is to resolve the risk. And so these intrinsic factors that are internal to the individual that make them the kind of person who gets suicidal instead of the kind of person who copes in other ways, it gets resolved, and therefore the suicide risk resolves.
The last step of our suicide care pathway is follow-up. So the Bree recommendations, ensuring the patient is connected to evidence-based follow-up treatment, and then contact and support during transition. So inpatient to outpatient, or from behavioral health to no behavioral health treatment. So on the bottom right here, so for example, this is just for example, if the primary care physician is prescribing antidepressant medication, so then there's going to be PCP follow-up at for example, at 2 weeks or 4 weeks for medication treatment. And then there's also going to be primary care follow-up during the course of the behavioral health intervention. So while someone is getting specialty care treatment with a psychotherapist, the primary care provider is following up and saying, how are things going? Any questions? How's it going with your medication? And then after the behavioral health treatment has resolved, there is subsequent follow-up in primary care. How did that go? How are things going now? Any additional need for follow-up in behavioral health or other specialty care. So here's a sample case example that Kate and I sort of talked about, like here's what it might look like if everything were ideal and it went through our workflow and the clinical pathway that we're describing. So for example, Joe is a 57-year-old man, unemployed for the past 3 months. He has back pain and is instructed by his wife to seek evaluation for back pain and depression. So we have man between the age of 35 and 64, unemployment, a situational risk factor, back pain, medical problems as another situational risk factor, depression, potentially a symptomatic risk factor. So we have a person at risk of suicide. So the risk identification, so the patient care coordinator, the front desk, gives the person a PHQ-9 as part of their routine clinic process with a clipboard. And so then for risk assessment, so the medical assistant takes a look at the PHQ-9. Joe has scored it as 2 out of 3. So more than half the days he's thinking about thoughts he'd be better off dead or hurting himself in some way. And so based on the positive scoring PHQ-9 number 9, the MA then gives the patient the Columbia Suicide Severity Rating Scale. MA then notifies the primary care provider that the Columbia is being completed. So then the primary care provider looks at the Columbia scale, thinks about and notes other risk factors, that this person is male, unemployed, has depression, and let's just say this person has a previous suicide attempt, attempted hanging in teenage years, so not within the past 3 months. So then primary care provider engages in risk formulation. So this person has endorsed suicidal ideation with method. So for example, Joe is saying, I've thought about killing myself again. In the past, I tried hanging. And so that's sort of what comes to mind now. Do you intend to do it? No, I have no intent. Have you planned out how you would do it? No, I haven't gone that far. So he has a history of suicide attempt by hanging in his teens, no other suicidal behavior. Based on the Columbia Suicide Severity Rating Scale risk formulation, primary care judges the risk as moderate, and then it goes down the hall to consult with the in-house behavioral health consultant, goes over the PHQ-9, the Columbia, and discusses the other risk factors. And so we have person at risk of suicide. Now we want to engage in management strategies to try to help keep the person alive. So primary care provider talks about medication treatment of depression, starts SSRI, talks to the patient about the role of the behavioral health consultant, and then escorts the person to the behavioral health consultant's office. So a behavioral health consultant engages with the patient, says, I've heard some things about what's going on with your life. Can we talk more about that? Can you confirm what I've heard? The behavioral health consultant works with the patient to develop a collaborative safety plan, and then schedules follow-up to look at a course of treatment. So behavioral health consultant engages in initial management and then schedules a course of psychotherapy to try to treat suicide risk. The course of treatment, a patient comes back later in the week, behavioral health consultant uses evidence-based practice. So let's say behavioral health consultant does the collaborative assessment and management of suicidality. And then on follow-up, primary care follow-up is scheduled for 2 weeks and 4 weeks to look at the medication treatment and how's psychotherapy going. The patient continues care with the behavioral health consultant for 10 more weeks, after which, or at which point suicidality has resolved, depression is better. Primary care follow-up is scheduled for 3 months out after the end of psychotherapy to see how things are going, make sure that things are improving. So that would be a sample of how someone might progress through these different elements of suicide care. So, Amy and Jenny, maybe we can open it up for questions. Any questions about this overview of care, barriers to implementation? We understand that we don't always have perfect healthcare delivery systems right now, about the components, about the case example. Any questions?
Yeah, can you guys hand me back the controls and I can check the chat box?
Yep.
And or you could also hit, I believe, unmute all participants and people could start asking questions as well.
I think you are the host now.
Okay.
There's one Q&A here. So I see a question about using secure texting apps when communicating with clients. Generally speaking, regular texting isn't really HIPAA compliant. This really comes down to 2 things. One is the personal limits of the, well, 3 things. The personal limits of the clinician, the personal limits of the the patient and the personal limits of, and the sort of agency limits of the entity within which you are working, and they vary, I have discovered, pretty widely. So I've seen systems where as long as the patient is saying, I would like to be texted on my regular phone, then they're welcome to do that. That's it. In this case, it's not a HIPAA issue because the person gave permission. And I've seen it all the way out to the other extreme. I'm starting to work with a county where we're planning care, and it'll all be through the HIPAA bridge, HIPAA protected secure messaging. Some clients don't like that. They don't want to have to use an app they don't really know. They would prefer to just speak otherwise. So you have to know kind of, we would never ask somebody to do something, the patient, the clinician, or the agency to do something they don't want to do. So I think that's probably, kind of case by case in terms of how people are interpreting this.
There's implementation issues about carrying contacts. So the randomized control trials are for carrying letters and carrying text messages. How that plays out in healthcare delivery systems is going to depend, as Kate says, on like what the healthcare delivery system can support.
There are also systems that have been designed specifically for primary care practices to be able to securely manage these text message communications where the person can use their own phone, but the system is HIPAA protected. So there's a whole range of pieces. Go ahead.
For treatment, what are your recommendations for the use of intensive outpatient programs or partial hospitalization for patients who may not need inpatient care but need more intensive treatment? So the patient is at risk of suicide. We are trying to use the least restrictive environment. So we are trying to avoid, for example, inpatient hospitalization. And so now we're talking about intensive outpatient partial hospitalization. I think that those are great options. I think that it depends on what the patient is going to need to keep their suicide risk managed. And again, I might continue to make that distinction between management versus treatment, because sometimes people have severe psychiatric symptoms and have high levels of life chaos. And so if someone has severe psychiatric symptoms and high levels of life chaos, then they need suicide risk management strategies to try to get those under control. And then over time, potentially on an outpatient psychotherapy basis, they can learn what is it about me, my background, my style of thinking that makes me prone to thinking about suicide as an option when life stress hits. And so I think that we might think about intensive outpatient or partial hospitalization as higher level management strategies, but I think that those are great options. It says, is there any guidance as to when a patient refuses help? Do you allow them to leave? How do you follow up? Okay, so we're talking about someone who's at risk of suicide and then is a treatment refuser. Interestingly, we actually have some of the best data for how to work with treatment refusers. So get caring contacts providing regular, non-contingent, we're thinking about you, we care about you over time without making any demands. We have some of the best evidence that actually prevents suicide. And so sort of in general, for a treatment refuser, you can sort of keep that in mind. Expressing unconditional support over time is a great way to implement suicide prevention for treatment refusers. But I think the question is getting more at, someone comes in, says they are thinking about suicide. Yes, I would do it this way. Can we get you some help? Absolutely not, I am leaving the clinic. And so now we're moving into the realm of, we're departing a little bit specifically evidence-based practice of what prevents suicide and into the realm of like clinical judgment and best practices. And so this is going to be based on your suicide risk formulation. So if you judge someone to be at near-term risk, clinical judgment, so nothing can like say yes or no, clinical judgment is this person is at near-term risk of suicide and needs immediate rescue, then you can start engaging in some of these non-collaborative higher level interventions. And so that might include calling the police for a welfare check. This might include calling the designated, what are they called now? DCRs, designated crisis responders, to do an assessment as well. So this idea of like, do you allow them to leave? So we're not authorized in our healthcare systems to detain people against their will. And so we can persuade them to stay, but like in regard to, can we hold people against their will? We can't hold people against their will. And then this idea of like, how do you follow up? So let's say someone has suicidal ideation, they have a method in mind, so they're at risk of suicide, but you in your clinical judgment, so you use your clinical judgment, risk factors, protective factors, warning signs, and you decide that they're at moderate risk, they do not need immediate rescue, but you know they're at risk of follow-up. So evidence-based practice, caring contacts would suggest that follow-up with non-contingent contact, how are you doing? I know that was a very stressful appointment. We are thinking about you. If you would like to come back in, we would be glad to see you. So, so that might be a suggestion. So if you judge them to be at immediate risk in need of follow-up, then you can start engaging in your higher level of interventions. If you in your clinical judgment decide that they are at moderate risk, do not need immediate like higher level intervention, then you can engage in a caring contact on follow-up. Kate, do you have anything, suggestions?
Yeah, so there was the study that Jeff's talking about with treatment refusers. There was also a large international trial that was using essentially a collaborative care model to do the same thing, to do a non-contingent. In other words, they didn't have to call you in distress. They didn't have to have they don't have to be in any kind of distress in order to have this contact, that it's essentially us in the healthcare system reaching out and just offering general support, not telling them what to do or anything they have to do, but simply acknowledging that we're there, that we care about them, and that we're happy to see them if they want to see us. That model also showed in this large multinational trial that people who received these ongoing contacts compared to those who didn't had lower rates of suicide and all-cause mortality. So I do think that it does, if you act, and whether you sent them home and then just kept reaching out, or you sent them, you ended up having to do something involuntarily, continuing to just reach out and express concern. One of the really game-changing experiences that you can have with this kind of scheduled contact is that that as I described earlier, suicide risk comes and goes. So more often than not, when you reach out in that sort of, we're just thinking of you today way, you catch them when they're not particularly suicidal, and then you have they often feel appreciated that you're thinking of them. And that's pretty much what they say. Thanks for thinking of me. I'm actually doing okay right now, and that sort of thing. And the other thing to think about is, if you want to be able to do this kind of caring contacts, is this something where you need a clinical management reminder system that I don't know if you have these sorts of systems for your depression care management or diabetes care management. People have, considered caring contacts is another thing to deploy with a reminder system. The alternative is this is a role for your behavioral health consultant to be able to reach out.
Just a quick comment about the treatment refusing. Part of the point of being suicidal is shutting down and refusing life. And so it's not, sometimes an analogy I will recommend is thinking about like the tobacco use and smoking cessation. So the top causes of death in the United States are like cardiovascular disease, neoplasm, stroke, etc., all of which like have as high level risk factor that smoking. And so, you know, we're all working with patients who are continuing to smoke. And so it has more of a motivational interviewing quality about it, that like you're always going to engage in management strategies. Like you're going to offer the person control of their blood pressure, control of their cholesterol, control of their weight. And then you're always going to say, I want the best for you anytime you're ready, anytime you're ready. And so that might be like one way of figuring out how to work with a treatment refuser.
Okay. Thank you so much for this engaged conversation and all of your questions and answers. I just re-put up the evidence-based treatments for suicidality scale due to a request for that in the chat box. And then I'm just going to fast forward very quickly to our last slide, which are save the dates for our next 2 webinars scheduled for March 25th and April 25th. Registration for the March webinar will be coming out within the next few days, and then April will come out toward the end of March, and more information on that, as well as potentially you could join our mailing list as all of the announcements and registration links are sent from there. Thank you so much, Kate and Jeff. Really, really appreciate your expertise. And we will be sending out all of the documents and the slides that we referenced today to all registered attendees sometime today or tomorrow. Thanks, everybody.
Thank you.